So let's start with the first one. This is based on a previous year question. So we will discuss it, how to approach, and then we'll discuss a few clinical points on this topic. So what do they tell you here? There is a 54-year-old male. There is binge drinking. So when you read these questions, you should highlight the keywords which give you clue to the diagnosis. So there is binge drinking, heavy meals, and he comes with sudden onset left-sided chest pain. There is subcutaneous emphysema. So heavy meals, chest pain of sudden onset, and subcutaneous emphysema. And a chest x-ray was done which showed air in the mediastinum, which is called pneumomediastinum. What is the likely diagnosis? So just don't jump the gun on seeing the question, also see the options. So what do you see? Some things called Mallory-Weiss tear, perforation, pneumoperitoneum, tension pneumothorax. So you should have a little bit idea about each so that you can eliminate the choices and get to the correct answer. Now what do you see here? There is binge drinking, after meals, there is pain, subcutaneous emphysema, and air in the mediastinum. That means from somewhere air has leaked, which means it can't be a pneumoperitoneum, because in that you will see free air under diaphragm. Right? The pneumoperitoneum means free air under diaphragm. Could it be Mallory-Weiss tear? Now Mallory-Weiss tear, there is no perforation. There is only a tear of the mucosa. It is also seen in people who have binge drinking, but there is a tear in the mucosa leading to hematemesis, which is not seen here. What is seen here is pain and emphysema. Tension pneumothorax, the chest x-ray would not show pneumomediastinum. The chest x-ray would show pneumothorax. So chest x-ray rules it out. Further, it would not be related to binge drinking. Further, it would not lead to chest pain. The main symptoms will be breathlessness, tracheal shift, hypotension, none of which is given. Thereby, you can call it esophageal perforation. And what you see, why is this esophageal perforation? There is pneumomediastinum. And this kind of perforation which happens after binge drinking and heavy meals is called as Boerhaave syndrome. So it is a spontaneous esophageal perforation, right? It is an esophageal perforation. Typically happens in the left lower esophagus, just above the diaphragm, in people who have a heavy meal after binge drinking, and it happens because of forceful attempt at vomiting. The person tries to vomit, but the glottis is closed, the cricopharynx is closed. So if the cricopharynx is closed, whatever he tries to vomit collects in the esophagus and the esophagus bursts. Typically at the left lower border of the esophagus, just above the diaphragm, right? So that is Boerhaave syndrome. That is why you got this answer by understanding, by application, by some buzzwords, and most importantly by elimination. So why is it not Mallory-Weiss tear? In Mallory-Weiss tear, there is hematemesis. Alright, so there will be history of binge drinking, vomiting, retching, but there will be hematemesis. There is no chest pain, there is no subcutaneous emphysema. All those findings are seen in Boerhaave, what is called as macular striae, right? So in Boerhaave, what you get is the macular striae. Very important clinical triad, where he gets chest pain. He tries to vomit, so usually there will be retching or vomiting. And there will be subcutaneous emphysema. That is your macular striae. So there will be retching or vomiting and subcutaneous emphysema, because the air from the mediastinum can also collect in the chest wall, right? How do you diagnose it? The investigation of choice will be CT with water soluble oral contrast. Okay, very important. You're not going to give barium, you will give contrast like gastrography. That will show you the site of the leakage in the esophagus. So you are going to use water soluble contrast. And the treatment of Boerhaave's, it's an esophageal perforation where there is a high amount of leakage because all the gastric contents leaked into the perforated site. So the treatment is going to be surgical repair. Alright, you'll have to do a thoracotomy, find the perforation. If you can close it, you may have to put an ICD if there is a pleural effusion also, and surgical management is the mainstay. Right, so important topic. It has been asked in the recent exams. This is inspired from a recent PYQ, right?